I'm Jason Lowenstein. I'm a scoliosis spinal deformity surgeon. I'm the director of scoliosis here at Morristown. And I'm going to talk to you today about scoliosis, spinal deformities, and spinal imbalance. So spinal deformity is really considered any type of imbalance or malalignment of the spine. It can happen in children, it can happen in adults, and it really can happen in any part of the spine. You know, typically when you look at the spine, it's supposed to look straight when you look at it through the front, and it's supposed to have these curves, thoracic kyphosis, lumbar lordosis, which balance the spine, keeps your head directly above your pelvis. So this patient obviously is imbalanced, right? That I was trying to give you a really subtle case of scoliosis. And so typically when you stand up straight and your head's directly above your pelvis, from the front and from the side, that's a pretty stable and controlled environment. When you start leaning forward, right, and you can't stand up straight, you start getting pain. As well, if you stand to the side, if you have a spinal deformity which causes you to shift to the side, that can also result in pain. So the French, and particularly Dr. Dubousset, sort of described this idea of the cone of economy, which basically means that if you're standing up straight and your head's directly above your pelvis, when you look yourself from the front and from the side, you have to expend very little energy to be in that position. And every degree off that main axis, if you start leaning forward or to the side or backwards, and you have to stay fixed in that position, you have to expend more energy to stay in that position. And over time, your muscles fatigue, you start having pain, and eventually you need to have an assisted device, like a cane, a walker, a wheelchair, in order to be able to stand up straight. So this is an example of that type of patient, right? This patient, this is the cone of economy, this patient's off to the right side, but also leaning forward, right? If you draw a line from their head down, they're in front of their pelvis. So these patients tend to develop progressive pain. So when I see a patient in the office, the first thing I want to do is take a history and do a physical examination and take a look at the patient, try to figure out, do they have a deformity and where's the deformity coming from? So in this particular patient, you can see a bunch of stuff. You see they have a crease right here, which shows asymmetry. You see that this shoulder blade's higher than this one, that shoulder's higher than that one. You're looking for that asymmetry, and you really have to actually have the patient put on a gown, look at their back. Sometimes you have to look at their front. You have to see if they have abnormalities in their chest wall as well. So there's a couple different patients, and these are young adult patients. But this patient obviously has a shoulder asymmetry. This patient has a significant truncal shift, their whole body shifting forward. You can see their scoliosis. This patient's leaning forward. These ribs are elevated. If you can't see that, this is a real obvious one. And there's this picture. When you see a patient with scoliosis, typically they're supposed to have a normal alignment when you look at them from the side. If they don't, then they have something else going on. Okay, so this is a patient who has curvature, right? That's not this patient. So this patient has Schroth kyphosis. They have curvature. They have wedge and multiple vertebral bodies resulting in a spinal deformity. Here's another patient, look at their back, right? This looks prominent, right? So this patient has a spondylolisthesis. What you're seeing is the spinous process of L5, because that's staying there and the rest of the spine is shifting forward. So these subtle cues can let you know that there's a spinal deformity that you have to deal with. You want to do a neurological examination. A lot of times patients with spinal deformity have a simple, straightforward scoliosis with no significant neurological changes. But particularly in adult patients, you can start seeing weakness because as they develop scoliosis, they can start getting spinal stenosis. My colleagues all discussed that. They start getting narrowing the space available for the nerve roots. They might start having radicular symptoms, pain going down their legs. They may have weakness or abnormal reflexes or sensation along with those changes. And then we get x-rays. And typically you want to get a 3-foot standing scoliosis x-ray, which is an x-ray of the entire spine. Okay, shows the neck, it shows the shoulders, it shows the spine, it shows the pelvis. Because you're looking for the entire spine as well as the alignment of the spine in comparison to where their head is relative to their pelvis. So we measure something called Cobb Angle. And a Cobb Angle is a way to describe how severe their curve is and what the degree is. There's a couple different reasons. One, you don't want to do this so you can talk to your colleagues and explain what their deformity is. But you do this also if you're watching a curve progress over time. You can say, okay, at this point in time, it measured this. And if it progressively worsens, sometimes that's an indication that you need to have more treatment. When do we order advanced imaging? It really depends, and it's very much on a case-by-case basis. But if a patient does have an abnormal neurological examination, oftentimes we'll get an MRI. And the reason why is we're looking to see if there's something going on within the spinal cord which would be both allowing the scoliosis to happen in the first place, but it potentially can make it worse. So this right here is this patient with the left thoracolumbar scoliosis, but this right here is a syrinx. It's a collection of fluid in the center of the spinal cord, not supposed to be there, and that can cause scoliosis, but also contribute to scoliosis progressing over time. So when do we get advanced studies like CT myelogram? You know, it's becoming less and less common to get those, but in patients that have stainless steel hardware, particularly patients that had surgery in the 80s and 90s, you can't see very well on an MRI, so we'll get a myelogram. So for anyone who doesn't know what a myelogram is, the radiologist will actually inject dye into the nerves, into the dural sac around the nerves. The dye will flow up and down. You start by getting x-rays, that's the myelogram, and you can see here's the dye flowing up, it stops here, it stops here, it stops there. That gives us an idea that the patient may have spinal stenosis at those levels, and then you get a post-myelogram CAT scan. And you can say severe stenosis here, and at L4-5 and L5-S1, where the patient had previous surgery, it looks like it's wide open. Okay, so what are the treatment options for scoliosis and spinal deformity? So there's a lot of stuff you can do, right? And we usually try to start conservatively. So you can give medications, and I think we discussed a lot of different medications already. You can try bracing. You can try chiropractic treatment. You can try physical therapy. You can try pain management and steroid injections, and eventually you can go on to have surgery. So for bracing for a second. So people oftentimes ask about bracing for scoliosis because they had a friend in middle school or high school who needed to wear a brace, and it's very typical to brace children that have scoliosis. The reason why is that the spines are still forming and modulating when you're young, right? Before you develop skeletal maturity, the bones are basically made of cartilage, and we can affect basically the way they grow by bracing. So the idea behind braces is you put a patient in a brace, you put a corrective force on the brace, and you're trying to straighten the spine in the brace to prevent the curve from progressing over time so they don't need to have surgery, okay? In adults, it's a little bit different because the spine has already stopped growing, and so bracing doesn't offer the same effect. So here's a picture of different braces. Typically, the idea behind bracing is that if you're going to wear a brace, you really need to wear it as much as possible in order to make it work. I like this picture because these are two children wearing braces. These are actually both advertisements to try to sell braces. This one is a flexible brace, doesn't really work, but she looks really happy. This is a brace, this is called a Milwaukee brace, which is back in the 60s and 70s. This is the happiest kid they could find to put in this brace to take a picture. Like, it's, you know, it's clearly not super successful, I'm sure, with that brace. So anyway, so in terms of bracing, we do have data that supports that bracing works in kids, and not to go too off the chart in this, but there's a guy named Stu Weinstein who did a study at the University of Iowa. It was a multi-center study. It was an NIH-funded study. For those of you guys that, care about peer-reviewed literature and all stuff, like, it's hard for orthopedics to get NIH funded to do stuff, right? I mean, you need to have lots of patients and lots of power, and this was a huge study, and the NIH pulled it after about 2 years because they said the data was so overwhelmingly supportive that braces work, that by not bracing kids with scoliosis, we were doing a disservice to the general public. Because what they did is they did a randomized study where they either had kids wear a brace, not wear a brace, if they were skeletally mature, before they reached 50 degrees, to see if their curve would progress. And there was a high correlation between not wearing a brace and having scoliosis progress. Does bracing work with adults? Well, bracing can work with adults at times. If you have scoliosis or spinal deformity and you have acute back pain, putting them in a brace sometimes can cool things off and make it feel better. The issue is that with adults, and particularly our geriatric population, when we put them in a brace, they have a different soft tissue envelope, right? Like, how well is this brace fit in this guy? The risk of skin breakdown, and how much is this thing actually doing for them? Probably very little. So you have to be a little bit careful. The other thing is that if you do long-term bracing in adults, really in anyone, but particularly in adults, particularly older adults, when you put a brace on, they aren't using their muscles, right? They become lazy. The brace is doing all the work. And they can become atrophied, and their curve can progress. So you have to be a little bit careful and judicious about when you're going to give someone brace. Physical therapy. Okay, so my, gestalt about PT and spinal deformities. I think PT is great, and I think physical therapy oftentimes can offer pain relief, particularly if you're trying to treat acute pain. However, the studies all show that physical therapy doesn't change the natural history of scoliosis. If you do planks every day in a certain position, it's not going to change whether or not your curve gets worse. Now, there are some scoliosis-specific physical therapy modalities out there. Maybe you guys heard of. There's something called Schroth, kind of become more popular in New Jersey because there's a couple different groups that are really promoting it and advertising it. But the concept is basically that these exercises are different than traditional PT because you're really trying to specifically target the muscles in your back to prevent scoliosis from worsening or make it better. And it was all started at the turn of the century. A woman named Katerina Schroth came up with this program in Germany. It was really to treat post-polio scoliosis. And it was really complex. And, she would have these head halters, and you pull on pulleys, and you look in the mirror, and, here's another one. It had a lot of manipulative therapy. There were group sessions. It was a whole thing, and it progressed over time. And then in the United States, in 2014, the New York Times wrote this article about Schroth PT. And there was a woman out in Wisconsin, his name's Beth Jansen, who was like the first person in the U.S. to really get notoriety for doing this. And all of a sudden, all these people started flying out to Wisconsin, and then obviously locally people started learning about it and tried to learn the techniques themselves to try to help improve, treatment for their patients. And it involves, all these different exercise modalities where you're working on bars and you're trying to strengthen your back, and the hope is to prevent scoliosis from worsening. And, patients that do it love it. Unfortunately, the data is not great. The data is, and the best data we have is out of Canada, and we don't have great data, but the data says essentially that people feel better when they're doing it. They think that they look better and they think they're good, but the curves are no different based on X-ray. I don't know that the data, the data's not there yet, and the jury's out on whether or not this works. However, it's really expensive. It's not covered by insurance. It's not a modality that's popularly recognized, and as a result, it's pretty expensive to do it. And it's not like you have to do it for a short period of time. You do it forever, supposedly. So you have to buy equipment. You have to do refresher courses. It's a big investment. So I tell my patients, if you have the resources to do it, it can't hurt you. But I just don't know if it totally works. So then you have surgery. So surgery for scoliosis really started around the turn of the century by a guy named Russell Hibbs, who did non-instrumented fusions for scoliosis. And basically, back in the day, most of scoliosis had to do with either TB or had to do with polio or had to do with infections. And you would open up the spine, you would lay down bone grafts, you close up the spine, you put these kids in a cast, and you put them in a cast ward for months. They'd lie there for 3 to 6 months, and then you start mobilizing them. It was pretty brutal. That changed in the 60s when we started putting in instrumentation. I'm sure some of you heard Harrington rods. Harrington rods, this guy right here, which was kind of like the first instrumentation system that came out. And there's a whole progression of different systems that came out after that. But it kind of really took a step forward in the mid-90s. There was a surgeon in Seoul, Korea, and Dr. Sook, who started putting screws into the spine. They're called pedicle screws that go through the pedicle channel that connects the back spine and front. And with that, you get incredible control, incredible power of your correction, and things really took a big leap forward. Having said that, there's a lot of concern about putting screws in, right? So this is a great example. So these are both pedicle screws. This pedicle screw is actually in the spinal canal, right? The spinal cord's in the spinal canal. There's only so much room for both, so it's not a great place to put it there. This screw is aiming right at the aorta, right? Both structures that are not great to mess with. So there was a lot of concern initially is, are these techniques safe, right? And so in the early 2000s, there were a bunch of papers that were written. And actually, it's totally safe to put in screws. And it's since then become really the gold standard. The other question is, just because it's safe, is it more effective, absolutely, suggested that the correction is way better. I actually wrote one of the papers when I was a resident, and there's a big difference. And to give you a sense of things, this is a good example of a case, right? It's one of my patients who's a 28-year-old who had progressive scoliosis, and you can see like how great the correction can be if you use all screws and shift them over. So the goals of scoliosis and spinal deformity surgery is really all about trying to get the patient corrected through the least amount of surgery possible, right? So we want to fuse the least number of segments and correct the scoliosis over the least number of segments to allow patients to have as much motion as they can, despite the fact that we're correcting it, but also cosmetically improve their rib hump and everything else to make them feel better. So this is an example of a young adult with scoliosis. She had progressive scoliosis. She had a right thoracic curve, which is kind of the most common curve. Did a bending x-ray, and it's a relatively flexible curve because she's a young adult. And these are her final x-rays, and you get a sense of how much you can correct a curve, with these sort of new modern constructs. So here's another one. This is what happens when the 23-year-old doesn't correct the curve. This is a 67-year-old, right, who developed a much more significant curve. This is actually an ICU nurse, ex-ICU nurse, who developed progressive scoliosis, and over time she developed progressive pain, right? I mean, as the curve, it's like an accordion, right? Like as this thing starts collapsing, you get more and more instability and more associated pain. So here are her bending x-rays. She was very stiff, and so here's the curve that we did, right? We had to fetch the whole curve. And again, the most important thing is her balance, making sure that her head is above her pelvis when you look at it from the front and from the side. Here's a different type of spinal deformity. This is a spondylolisthesis. Dr. Rieger was just talking about this. So this is a high-grade spondylolisthesis where L5 is fallen off at S1. It happens because you wind up getting a pars fracture, which is a stress fracture in the back of your spine right here. And over time, if it breaks on both sides, the disc is bearing the majority of the load. And as the disc wears out and you start slipping, you get that. High-grade spines are way less common, but they happen. This could happen. This is the classification. You measure it based on how far it slips. But here's this CAT scan, and you really get a sense of how far L5 is slipping off of S1. Here's the MRI, and shows it as well, and these are the views. So at the level where the high-grade slip is, the nerves are getting really crunched. So this is the level above, right, and all that space is for the nerves. This is the level of the slip, so it's pretty tight. So this is a kid we fixed, and we did it all from the back, and we basically went in, we put in our screws, and reduced the spondylolisthesis, and then we put an interbody cage in, which is that spacer between L5 and S1 as a load-sharing device to basically try to get it to heal in the front and the back, but also to make it more mechanically stable. And you get a sense. This is his final x-ray. And to compare the two, this was the slippage, right? And this is where it is now. So to sort of show you more extreme examples of that sort of cone of economy and imbalance, here's another patient, right? So anyone who would see this patient walk in our office, right, this is not compatible with like a happy life, right? This lady's way bent forward. She has severe thoracolumbar kyphosis, severe kypho-Scoliosis, and she's miserable. Coincidentally, she's an ICU nurse. Something about being an ICU nurse. This is the myelogram. She has severe spinal stenosis. So this is her preoperative x-ray. This is her postoperative x-ray. And so what we did is we went in from the back. We put in screws from her upper thoracic spine down to her pelvis. We did osteotomies, which means we removed bone and soft tissue at the levels where she had the deformity, and we straightened her up. And you get a sense of what they look like pre and post-op. And it's a huge improvement in their quality of life. Here's another patient, a little more complicated. So this lady had surgery, right? She had a T10 to S1 fusion at an outside institution, and wound up developing severe kyphosis above. So her head's over here, right? And her pelvis is over here. That's, obviously she had severe deformity, but severe pain. So because this patient had a fusion from here to here, that's a solid block, right? But in order to correct the deformity, you got to take a big wedge out of that. But you have to do it carefully because you're working around the nerves to do it. So we did something called a pedicle subtraction osteotomy, where you take this wedge of bone out. But keep in mind, the nerves are all here. So we're working around the nerves the whole time, take this wedge out, and then we close the wedge to create the lordosis that she doesn't have. Right? So you get a sense of how much better they can get after that. And it's all here. It's that deformity. It's cutting the spine there and bringing her upright. And you get a sense of what they can look like once you correct them and fix them. Okay? Last case. Because sometimes we meet these deformity patients in the hospital, right? This is a consult of mine. This is a 70-year-old guy who came in. So for anyone who can't see, this is his back, right? It's sticking out right there like a hook. It's never a good sign when they have a pain patch here and they have this covering a wound. So basically, this guy had been treated for discitis and osteomyelitis for about 3 months. And he came in with progressive pain, inability to stand up straight. Here's his x-ray. And he has severe kyphosis, right? He can't stand up straight. And that's because at the levels where he has his infection, the osteomyelitis has caused the bones to be destroyed, collapse over 2 segments. There's also a big piece of bone, infected junk pushing backwards into the spinal canal. So this guy was doing terribly. So we took him to the operating room, and you can see just on positioning, he still has that hook there. He has this horrible skin ulcer over the hook, right? And we did surgery on him. So what we did is we went through the back first. I put my screws in. I did osteotomies at the level where he had his deformity. I straightened his spine. And then on the second stage, I went in through the front and I took out those infected, dead, destroyed butchered bodies and put in an expandable cage to help support him from the front and the back. And that's what his pre-op looks like. That's what his post-op looks like. That's what he looks like. And big difference, right? So ultimately, back to sort of peer-reviewed research. So some of the best stuff that's come out was through the Spinal Deformity Research Society. And if you look at the outcomes of treatment for adult spinal deformity, the quality of life outcomes and the overall patient satisfaction is way high for spinal deformity surgery when it's indicated. Much better than conservative management for these types of complex deformities. So there really is a role for this. And finally, this guy right here, right, getting major error on his board, was this patient who became this patient, who's my patient. And he's a competitive snowboarder. So I mean, you can do a lot after you have scoliosis surgery. It's really about identifying the right patient and fixing the problem when you have it. So thank you guys very much.